So I should mention that the type of fracture varies, and if you've got an impacted fracture that's fairly solid, they're going to do well in the bed. They don't need a surgical operative reduction internal fixation because they're relatively stable. If you can move their knee around, move their knee up and down a little bit and they're not all that uncomfortable, that's a good predictor for doing well in bed. If they're exquisitely painful every moment that you touch them, then you may have difficulties with pain control, and if they're iffy, if they're possibly going to survive, absolutely we're going to try and fix those as a pain control measure. So the degree of instability of the fracture is also a part of this equation. Phil? Okay, so two-part question. The first was pain control and difficulties of providing pain control, and the other part was, are there other fractures that we would apply this to? So pain control, absolutely, it hurts when you move and it doesn't hurt when you don't move. So let's try and minimize the movement and make it as comfortable as possible. If the fracture is stable and not moving much, life is easier. If the fracture is quite unstable, then it's more challenging to provide care. And absolutely, you have to find that balance. And here's the key. We absolutely need an engaged physician who's working very successfully with the nurses as a team. The physician needs to be available on the phone, and you need to be titrating your narcotic doses. And the nurses need to be comfortable with titrating narcotics and doing a good job of that, and very confident in talking with families about this. You need to talk the family through this. Dad is now actively dying. So we've just gone from advanced illness to actively dying. When you break your hip, you are now, by my definition, actively dying. Yeah. And that breaking point is key. Lots of questions here. I'm glad to. So the other question is, are there other fractures? Pelvic fracture, you treat with bed rest, and they mostly get better. Almost all of them get better from a pelvic fracture. Yeah. You guys have all seen this. They don't want to weight bear, but the x-ray shows no fracture. Do an x-ray of the pelvis. It's an occult pelvic fracture, and they don't want to weight bear, and they will weight bear in six weeks or so. That's one. Extremity fractures, wrist fractures, that kind of stuff. A cast reduction, that's a comfort measure. I would not ever fail to treat an extremity fracture. If it's a foot fracture, oftentimes I go to the emergency, I get some orthoglass splint, I make them a splint right there in the nursing home. Yeah, immobilize that fracture, absolutely. Have I successfully answered all of your questions? Yeah, okay. Two other questions here.
Do you ever cover them with Fragmin?
Do I ever cover them with Fragmin? They're actively dying. I stop all their pills. This is a red flag that it's time to go through every single medication on the list and stop everything that they don't need. Yeah. Okay. Active skin issues when they're immobilized, yes, that's an issue, and you need to move them enough to keep that under control without causing them undue pain. And special mattresses, thank you.